Hi, this is a 37-year-old lady with typical symptoms of reflux and heartburn, and that's the endoscopic picture. The manometry shows good esophageal peristalsis. That's the port position for the robotic fundoplication. Two 8 mm ports for the left and the right hand, and an assistant port of 10 mm in the in the anterior axillary line for the assistant port. So I'm using two instruments. I'm using the scissors on the right and the bipolar fenestrated bipolar on the left. The assistant port is used to use the bipolar energy device, the Ligashore from Covidian. Because we don't have the vessel sealer yet, along with the HUGO RAS, we have to use the assistant port for using the bipolar device from the assistant port. So once we have partially done the gastrolysis, we are isolating the right crus as well as mobilizing the esophagus all around. So that's division of the phrenoesophageal ligament. We'll be using three instruments in this case, the third being the needle driver later on. So that's bearing the right crus and making a window on the other side. So the steps will be same as replicating the laparoscopic fundoplication. It's important to mobilize the fundus completely from the left crus. So the left crus needs to be bared completely. And then the esophagus needs to be mobilized all around circumferentially for at least 5 centimeters so that the esophagus can be brought down, so as to have the wrap on the esophagus. Now division of the short gastric vessels completely is very important. Here we are bearing the lower part of the left crus. The Ligashore is a very versatile instrument. All the short gastrics should be completely divided so that the fundus can be made free for the wrap. We hope that in some time we'll have the vessel sealer also. That will make the job much easier and it will reduce the reliance or the dependence on the assistant. So as you can see, I only have the monopolar device on my right, so it's a little bit oozy. We have preserved both the anterior and the posterior vagus. The vagus you can see below the esophagus, and we are mobilizing it as far above as possible. That's the remaining part of the omentum, as well as the short gastric vessels that are being divided to create a wide window. So this far we have just used two robotic instruments, and for the suturing part we'll be using the needle driver. So this is a 15 centimeter barbed suture. It's a V-lock 20. You can also use Ethibond for closure, but V-lock has made our lives very simple, very easy for the suturing part. And it's important not to make it very tight, but have enough space for the food bolus to pass through. And we have also to ensure that it should not be tight so that the crural fibers are not strangulated, but just opposed. Right. Now we move on to the wrap. You can see that the wrap is not going back even after we leave it, and that entire wrap is on the lower part of the esophagus. We don't tend to take the esophageal fibers in our first bite. The first or the second bite we just take it with the fundus so that the wrap can be slided upwards as much as possible later, so that the wrap stays on the esophagus. All these precautions are so that the patient doesn't have any post-op dysphagia. You can see that the wrap can be slided upwards now. So the entire wrap is on the lower part of the esophagus, and in the third bite we'll be taking some muscles of the esophagus so that the wrap doesn't migrate, it stays there. So this is an Ethibond we are using. We also ensure to take a single bite from the fundus and fix it to the crura so as to prevent the migration of the wrap. Thank you so much.